Okay, yeah, so we'll go ahead and get started. I'm so glad you all could join us today. My name is Allison Foster. I'm the Executive Secretary of Delta Omega, and I'm going to be hosting today's presentation. So hopefully you all know, if you're on the webinar, that Delta Omega is the Public Health Honorary Society founded in 1924. There are currently over 130 chapters at CFA-accredited schools and programs. We've inducted well over 30,000 members since our inception. And we're really excited to be celebrating our 100-year anniversary this year. So one of the ways we're celebrating the anniversary is by hosting a series of webinars that look back over the past 100 years, and we're featuring a milestone during each decade. So I'm very pleased to be able to introduce you to today's presentation, Public Health in 1960s, the Civil Rights Movement March Towards Health Equity, Miles Traveled and Miles to Go. It's going to be presented by faculty at Nova Southeastern, the Alpha Chi chapter. So the presenters will be Dr. Stacy Pinnock, Dr. Jason Forbes, Dr. Lucas Holler, and Dr. Christy Navarro. So they've got a great presentation for you today. If you've got any questions, go ahead and put those in the Q&A, and we'll save a little time at the end to answer questions. Thank you very much.
Hello, everyone. My name is Christy Navarro. I'm an assistant professor of public health here at NSU. I am also the president of the Alpha Chi chapter here in the public health department. I will be serving as your moderator today and getting us started. And I'll give an opportunity for my colleagues to introduce themselves before we get started.
Good morning, Dr. Stacy Pinnock, also assistant professor at Nova Southeastern University's College of Osteopathic Medicine. And I am the most recent vice president of the Delta Omega chapter here at NSU.
Good afternoon. I'm Dr. Lucas Holler. I'm an associate professor within KP-Com, Department of Public Health. I am a proud member of our Delta Omega chapter, and I'm happy to be here with you today.
Hey everyone, my name is Dr. Jason Forbes. I am also a professor, assistant professor here in public health at Nova Southeastern University, and I think I'm probably the newest member of the Delta Omega chapter here at NSU. Glad to present.
Thank you, Dr. Forbes, Dr. Holler, Dr. Pinnock. So we are going to get started with our presentation today. So our objective is to discuss how the civil rights movement has aided in the progress towards health equity by challenging structural racism. For our agenda today, we are going to begin at the beginning where we started. Then we will discuss the civil rights era, as well as where we are now and our future, what that looks like for us. I will be hosting the moderated discussion and have an opportunity for Q&A with my colleagues. So we are going to get started with Dr. Pinnock. Take it away.
Thank you. All right, so let's start from the beginning, right? So we're going to talk about history moving towards at least 1963, where we have a better understanding of where the civil rights movement kind of began and where it headed towards. So I want to give a little bit of a framework regarding health equity. Next slide, Dr. Navarro, thank you. Okay. Dr. Navarro, can you advance the slide? Maybe not. All right, so let's talk about health equity. Thank you. Okay, so we're framing this whole conversation around health equity. So the attempt in public health is to move towards health equity. We know that there are a number of disparities in our health outcomes across groups, and specifically groups related to race in this instance, and that's what we're talking about today. So health equity, defined by Healthy People 2030, is the attainment of the highest level of health for all people, right? In this conversation regarding moving towards health equity, we're looking at the opportunity for each person to be as healthy as possible, and looking at the systems, the structures, the determinants that support them to become as healthy as possible. So oftentimes when we're looking at the conversation of health equity, next slide, please, we see this image, and I'm sure many of you are familiar with this, also put out by Healthy People the early years, I believe 2010, looking at health equity in terms of resources given so that we can have a fair opportunity to reach equal health outcomes. Oftentimes, though, this depiction of health equity gets under the skin of some individuals. People look at it as we're taking away resources from one and giving it to another person. So I often like to use a different image of health equity. Next slide, please. I like this image a little bit better, or images similar to this, where we're looking more so at the fit. So health equity, looking at the fit of an individual. So when we look at equality, if everyone is given the same bicycle to use, and depending on their stature, their status, their ability, and perhaps even their knowledge, it doesn't work out the same way, right? Because they don't necessarily have the same opportunity to move. Whereas an equity would show that we are giving what is needed or what fits the individual for them to have the same opportunity. Okay, so we see here that the individual who would need some kind of accommodations, they have accommodations in a different bicycle type altogether. Some are bigger, some are smaller. I would even suggest we should have had a picture with one with training wheels, right? So it fits the need of the individual. Next slide, please. So when we're talking about health equity and we're moving towards this conversation of trying to attain health equity, in this instance, when we're talking about the 1960s, we want to talk about certain policies, certain milestones that gave way to the rise of health equity by challenging racism and structural biases in the system. So structural racism as a framework, these are the ways in which racial discrimination is embedded in society through our systems, right? So through social, legal, political institutions. We can talk about incarcerations in the criminal justice system. We can look at employment practices, hiring practices, opportunities for education, even healthcare and biases that we see in healthcare practice. So structural racism are fundamental causes for health inequities. And these are the things that we're trying to challenge. So starting from the beginning, let's move towards where we began. So we're going to talk about the 1960s, which is a decade known for protests, social reform, and marches towards equal rights, and marches used in both the literal and in the figurative term. But if we take it back 100 years, so in 1968, the 14th Amendment to the Constitution gave Black people equal protection under the law. And then in 1870, the 15th Amendment granted Black American men the right to vote. So we already had some movements happening prior. So after after the war, before the Second World War, and after the First World War, we had some movements already. However, in 1996, there was the first, we'll call it the first issue of giving up a seat, right? So Plessy versus Ferguson in Louisiana. So an individual, his name was Plessy, he bought a ticket for a train in New Orleans. It was to go to Covington, Louisiana, and he took a vacant seat under the whites only section of the train. This individual happened to be 7/8 white and 1/8 Black. And in fact, he was arrested and jailed. And so it became a conversation there. In this instance, the law actually sided with the prosecution and decided that Black individuals can be equal, but separate. Okay, so having equal rights did not necessarily mean that there should be equal social status within certain settings. That included institutions, that included the restrooms and such. Okay, so this is where we started. So we're going to watch a little video, just 2 minutes, showing us the progression towards the civil rights movement. So we have no sound, Christy. Should we stop and share it again with the sound?
I think it's a Zoom issue.
Christy, maybe
Nearly
if
a
you
century after the end of the Civil War and the dawn of Reconstruction, African Americans still found themselves fighting for their basic rights as citizens. The modern civil rights movement in the mid-20th century finally secured them.
Most historians actually date the start of the formal civil rights movement to Brown versus Board of Education. Brown really stokes the fervor of the nation. Then, in December of 1955, Rosa Parks decided as an act of resistance that she would not give up her seat to a white man on the bus.
Rosa Parks' deliberate act of resistance led to a bus boycott that thrust into the limelight a young preacher with a PhD. He would become one of the movement's most charismatic leaders. His name was the Reverend Dr. Martin Luther King Jr.
One of the most iconic moments is the March on Washington in 1963, led by Martin Luther King Jr.
200,000 people converge on the nation's capital to rally for civil rights. They come united in one cause.
One day right now in Alabama, little black boys and black girls will be able to join hands with little white boys and white girls as sisters and brothers. I have a dream today.
This becomes visualized on the news and begins to change the way that Americans are starting to think about the civil rights movement.
As the civil rights movement attained greater visibility, it was often met with increased brutality and violence. Yet in the midst of so much sacrifice and heartbreak, the work of civil rights activists began to bear fruit.
In 1964, President Lyndon Johnson signs the Civil Rights Act of '64, and that's designed to desegregate businesses and government employment. And then in 1965, President Johnson signs the Voting Rights Act of '65.
The passage of the Voting Rights Act was a monumental victory for African Americans. Tragically, just 3 years after it was passed, Dr. King would be assassinated. Many feel, looking back, that the movement died that day. But in fact, the movement took on new forms and continued. And it must continue today as a...
Awesome. Thank you so much. Okay, so looking at how we moved, we can talk about where we started, and then we're going to talk about what happened in the civil rights movement and where we're going present and going forward. So let's talk about 1960. In 1960, specifically, the average life expectancy across the board was 69.8 years. So you can see it's a whole 10 years younger than what it is now. So this information is gathered from the National Center for Health Statistics, and I will say that where it says Black, the actual data stated non-white, and we're going to count it as Black because 93% of the non-white population in the US at the time were Black, and so we use those numbers for the Black population. So we can see the difference in terms of the life expectancy, men versus women, which has not changed. But looking at Blacks versus whites, you can see a stark contrast in the difference in the life expectancy, and that's in 1960, a difference of at least 6 years. We also talk about the overall mortality rate, infant mortality rate, which was 26.3. That's overall for 100,000 of the population. However, it is almost double for African Americans, and that's in 1960. So this is where we started. So moving forward, I'm going to try to redeem the time a little bit. But we'll talk about some of these Jim Crow laws that we saw where they kept this whole idea of separate but equal. And the idea of separate but equal resulted in limited employment opportunities, the fact that individuals were living in certain neighborhoods. So because there were limited lending practices at the time where Black individuals were not able to get loans for their housing. And so it resulted in certain residences, certain communities of Black individuals living in similar situations. That also caused the wealth gap, right? So if we're having trouble with home ownership and having land and housing, that created some differences in terms of being able to gain and pass on wealth through generations. We also saw differences in education due to segregation, and also due to where individuals were living and not having positions in the neighborhood or in the area, they had lack of healthcare facilities, and it wasn't the same. What they did receive was not the same. So the slides going after this, they're all talking about the civil rights movement and the timeline going forward. So in effort to redeem the time, I'm just going to go ahead and pass on and move from 1954. The video talked about these times, which lands us all the way into 1957 with the first Civil Rights Act, giving opportunity for Black individuals. They had the right to vote, but in this situation, making legislation where it was illegal to stop the vote of individuals. And I will pass it on to Dr. Holler to take it away.
Thank you, Dr. Pennick. So leading us up to where we are now within the civil rights era, moving forward to the next slide, what's impressive about the civil rights era and the 60s in general is just how much crazy stuff was going on. It was such a time of turmoil. I was not alive during the 60s, believe it or not. But something that makes me feel better about our current social, historical, political context is that I try to convince myself things were crazier in the 60s. I don't know if that's accurate or not, but that's what I like to tell myself. Because think about what we were up against globally and domestically. We were looking at the civil rights movement, Vietnam War, countercultural movements, Black Power, political assassinations, rock and roll, Cuban Missile Crisis. Fun side note, also the transition from AM to FM radio in the 60s. Women's liberation, gay liberation and Stonewall rights, sexual revolution, all the construction of the Berlin Wall, landing on the moon, 69, Castro, Guevara, the Latin American revolutions, all this was taking place simultaneously. So when we transition to the next slide, we can think about what's going on specifically within the United States. No, she didn't catch my smooth segue. There we go, fantastic. So domestically, in the midst of all of this, it's fascinating to think how historically there's so little time between the Civil War, through Reconstruction, to World War I, to World War II, to coming into the 60s, such that we still had rampant amounts and types of poverty that go even beyond what our imaginations of current poverty show us. The segregation and prejudice as well being much different in type and scale than it is today, despite how it feels today. So during the 60s, specifically during the Johnson administration, we saw this explosive movement of policy by way of the Great Society and the War on Poverty. There were nearly 200 pieces of legislation that Johnson signed into law in as little as 5 years, addressing civil rights, poverty, education, health, arts and media. For all of you public radiophiles in the room, that's when public broadcasting came into its being, PBS and NPR. Environmental protections, housing and urban development, consumer protections, and immigration issues, all wrapped up within the Great Society initiative. And as a fun side note, since we are talking to public health folks, tobacco restrictions, the tobacco restrictions as we currently know them got their start during the Great Society with regards to putting warnings on tobacco products even. Now, if we move into the next slide, we can start thinking about if the Great Society and the War on Poverty are taking on all these different policy areas, As public health professionals and scholars, clearly our brains are already connecting to the social determinants of health, the conditions into which people are born, live, work, and I like to say die. That's not included in the usual definition, but I think dying is pretty important. So as a result of that, we're all familiar with the categories of the social determinants of health. And if we just look at the legislation on the right-hand side of the screen, we quickly and easily start to be able to tie together the substantive policy efforts taking place within the 60s, specifically during the Johnson administration, and the categories of the social determinants of health. Let's tease that out a bit more explicitly by going to the next slide and looking at individual components of these pieces of policy and their explicit connections to the social determinants of health. In terms of education, Civil Rights Act Title IV actually forced through federal law, the desegregation of schools. The Supreme Court had already moved in that direction. This was codifying it into law at the federal level. Additionally, the Economic Opportunity Act of 1964, although not technically a civil rights act, is frequently seen to be a civil rights act due to a number of provisions within it that helped to try to address inequities we experienced as a nation at the time. For example, the introduction of Head Start program, which exists to this day and to this day remains controversial for the role of whether or not the federal government should be involved in such educational programming for pre-kindergartners. Clearly, though, in terms of getting kids ready to compete at day one of first grade or kindergarten, and the subsequent trajectories that result from an inability to be on the same level as your peers in first grade, resulting in third grade reading scores, that can be used to predict the number of jail beds that we'll need after graduation whenever these kids drop out. Clearly important policy for education and equity. In terms of housing, the Fair Housing Act of 1968, banning discrimination in terms of renting, selling, buying of housing. Employment, Civil Rights Act Title VII, making it such that you cannot discriminate based on race and a number of different items. And interestingly enough, companies owned with 25 or more workers, if you have less than 25 workers, you can still discriminate at the time. The Economic Opportunity Act also included Job Corps, so that underserved, vulnerable populations could enroll in job training programs in order to get them prepared to compete on the labor market. Job Corps as well still exists to this day. In terms of healthcare, perhaps an important category of the social terms of health for some folks in the room, Title VI of the Civil Rights Act introduced the important idea that you could not discriminate in federally assisted programs, which would find itself playing out in terms of Medicaid, which we'll look at shortly. Along those lines, the Federally Qualified Community Health Centers, the CHCs, at the time they were called Neighborhood Health Centers, based off of a model of care coming from South Africa, interestingly enough. They were introduced by way of the Economic Opportunity Act. And then of course, we saw the amendment to Social Security in 65, introducing us to Medicare and Medicaid, technically both programs building off of previous works, but trying to expand them and to near universal coverage. And then finally, and we'll get more into Medicare and Medicaid shortly. And then finally, voting. Now, the Civil Rights Act of 64 did include in Title I efforts to protect voting, specifically looking at voter registration and making it such that minorities did not experience greater burdens to registering to vote. But it didn't take long for folks to realize that the efforts employed through Title I weren't sufficient, which resulted in subsequent policy work leading to the Voting Rights Act of 1965 that not only made it illegal to impose barriers to folks registering and actually showing up and voting, but also made it such that the federal government could monitor the voting at the state level when there's concerns of racial discrimination and denying people fair access to voting. Additionally, there had to be pre-clearance when states that were known to have experienced and implemented racist discriminatory policies would have to be pre-cleared by the federal government as they worked on their voting laws and tried to protect the voters from further disenfranchisement. So I want to use this notion of voting to take us from something that I think we're all familiar with, the social determinants of health, and transition us into the next slide where we talk about the political determinants of health and how they are at play within the civil rights movement and efforts to establish and ensure equity in the United States of America. So whenever we talk about the political determinants of health, if you've not yet come across it yet, according to Dawes in 2020, we're looking at the political determinants of health involve the systematic process of structuring relationships, distributing resources, and administering power that mutually reinforce or influence one another to shape the opportunities that either advance health equity or exacerbate health inequities. So what we're getting at here is that the political determinants of health, the relationships that exist between parties, between interested entities such as lobbyists, professional associations, elites, you name it, the extent to which and ways in which these relationships form, and the way resources, political capital, financial capital, cultural capital are distributed across society, and the way we actually implement our policies through the administration of power, these things lead to the determinants of the social determinants of health. The SDOH are the consequence of the PDOH. And so if we transition to the next slide and start looking at some of those pieces of legislation that we looked at a second ago, we can start to see the severe impact of PDOH on the SDOH and efforts at equity. Now, we started this section talking about the social, historical, cultural context of the 60s. Policy scientists like to talk about flux, focusing events, moments in history wherein there's such chaos or change going on that it literally shakes political systems and results or gives the opportunity to result in significant policy change. So that's what we're looking at in the 60s. And check it out, Democratic supermajorities in the Senate, the 87th through 89th Congresses, you saw a supermajority of Democrats in the Senate, a supermajority in the House, 290 Democrats in the House and the 89th Congress. Think about the power Kennedy and Johnson had during this time to push through policy. Now, some of us in the room are of a particular age. We're thinking to ourselves, a particular age and particular political orientation, perhaps, we're thinking, wow, could you imagine what we could get done with that type of representation? And other folks in the room might be scared about what that looks like. But older folks in the room are like, well, no. You're forgetting the history of the political parties. Because sure, the Democrats might have had these supermajorities within the House and the Senate, but we're forgetting the differences that exist among the Democrats back then. Because really, we were looking at a Congress where we had Republicans, Northern Democrats, and Southern Democrats. And the Dixiecrats, as they were called, had much different sort of worldviews and political ideologies than their brothers and sisters in the North, who happen to be of the same party. So if we look at the next slide, we can start to think about particularly the role of federalism, the power and responsibility sharing between the central government and state governments, the Jim Crow South, which has its own separate but equal laws that were in place until forced out of the way by the federal government, and access to healthcare. For the sake of time, let's contextualize this idea of the political terms of health and health equity during the Civil Rights Movement and look at healthcare. The amendment to the Social Security Act in '65 that resulted in Medicare and Medicaid, Medicare had broad general support and appeal. Let's take care of old people, right? In terms of policy imagery, who doesn't want to take care of old people? So there was broad consensus that sure, let's have this national, federally administered program to provide government health insurance to seniors. But because of federalism, the power and responsibility sharing between the federal government, the state governments, and the Jim Crow South, there were differences between the Northern Democrats and the Southern Democrats in terms of the types of support they wanted to see for a national, federal, or administered government health insurance program for the low income. Because due to the structural racism, as I mentioned earlier in our presentation of the times, the economic structures, political structures, social structures that existed, poverty was a greater burden for minority populations than for white populations. So any federal effort to improve access to health care through way of government health insurance for the poor inevitably was going to run into issues of race. And in order to get Medicaid through, there was a compromise between the Northern Democrats and the Southern Democrats to allow the states to be in control of administering the program. That way, states in the South could still find ways to try to impose their worldviews on a program being required by the federal government. Now, we can still see issues of this at play now in our current Medicaid context. I'm starting to create the segue into Dr. Forbes' talk, where he's going to move into where we are now and going in the future. But currently, take a look at a map of expansion and non-expansion states. And when I say that, I mean states that expanded Medicaid as a result of the Affordable Care Act and states that did not expand Medicaid. You'll find that a number of those non-expansion states are in what we used to refer to as the Jim Crow South. Medicaid work requirements. There's only one state that actually implemented work requirements for Medicaid, Arkansas. It didn't last too long because it got shut down in the states. Indiana considered doing it, but they never actually started enforcing it. But guess what? Georgia's on it right now. Georgia has received approval from the Trump administration to implement work requirements for this Medicaid program, and has been thinking about how to do so. In scholarly research, there's even an article published in Health Affairs, talks about whether a work requirement is implemented for Medicaid will have adverse impacts predominantly on minority populations due to a number of structural issues at play, and providing evidence that one is in fact working, and then trying to get back on Medicaid once one gets kicked off, if one loses eligibility through an inability to demonstrate that one is working. So there's a number of issues that we're still up against. So segueing into the next slide, it's interesting to think about how the way in which Dr. King could even be seen as a health policy scholar. When, this was new to me, but of all the forms of inequality, injustice in healthcare is the most shocking and humane. And I think that's still particularly prominent and poignant for us as Americans right now. Dr. Forbes, take it away, sir.
For sure. I appreciate the transition. As we talk about now miles to go, the biggest part that we want to think about is how are we connecting first the past, what happened in the 1960s, maybe some policies that happened in the 1970s to where we are now. As you go to the next slide, Dr. Navarro. And as we do that, we're gonna do some callbacks to some of the information that Drs. Pinnock and Holler has mentioned before. So if you remember, she mentioned in the 1960, the average life expectancy was around 69.8, approximately around 10 years, maybe about 8 years lower than it is now. But now you see this data is from 2021 using the same sources from the CDC. You see that it's 71.2. So it went up and went higher. However, there's still going to be some form of disparities there. So you see when we compare in terms of gender and race at the same time, so you see Black women compared to white women, you see in the 1960s, there was a difference between around 8 years or so, just under 8. But now if you look at 2021, yes, those advancements, of course, overall in healthcare and medical services and making sure people last and live a little bit longer, you see that there's still a difference here of approximately around almost 5 years, just under 5 years between Black women and white women. And then when you look at Black men and white men in general, you see there's still a significant difference here. In actuality, it's either around the same or worse in terms of where we actually came. And then when you look at the infant mortality rate, as you've seen, of course, again, through the first few statistics, there has been a dramatic increase overall with healthcare, right? You've seen a significant reduction in infant mortality rate between everyone, where you had the overall 26.3 per 1,000 people in terms of infant mortality rates, compared to now where the overall average is around 5.42. But in both instances, individuals who considered African-American or Black had the worst outcomes in terms of infant mortality. So you see 44.3 in 1960 compared to now, which is still the worst out of any of the races that were actually surveyed and obtained in 2020 at 10.38 overall. So there is improvements for all these various healthcare outcomes, but there is variations when we're actually talking about the racial and when you have the combination of gender as well, structure in terms of their specific outcomes. Next slide, please, for me, Dr. Navarro. And then when we talk about kind of looking back at what Dr. Holler was mentioning and some of the advancements in certain aspects, right? We talked about how did legislation actually help try to minimize a lot of these disparities that are there, right? But we've had some more, right? Not necessarily exactly the same as the 60s, because as Dr. Holler mentioned so beautifully in his talk, a lot happened in the 60s and around that time during the civil rights era. So we kind of see everything leading afterwards, right? So you see in education, you have the Strength and Diversity Act of 2021 that was introduced. It was not passed. It was actually stopped at that very introduction. And essentially, it is promoting diversity in education. It is promoting figuring out ways of providing education to others of kind of different backgrounds, whether it's racial, income, and or ethnic overall. Unfortunately, this bill was not passed overall. It stopped at the introduction phase because, of course, there was a lot of everything else going on at the time too. I mean, there was just a pandemic that was also going through at the moment. So I'm sure there was a lot of other things going on in order not to pass this specific act at the moment. But of course, if you all know about education, oftentimes, if not all the times throughout the country, it is funded by income tax of a specific location. So this has actually previously been identified oftentimes as one of the areas for disparities. As Dr. Holler was mentioning, we did have housing discrimination historically throughout the United States, where individuals were allowed in certain areas. And of course, if you have various employment disparities and kind of discriminations back in the 1960s, 50s, of course, you're going to have people who are traditionally going to live around the same communities. So on top of that, if education is now funded by where you're located based on income, more than likely, if you continue to go on, you're still going to have an area where you have communities who are going to be primarily African-American having lesser resources devoted to their education due to that income-based resource education allocation, I should say. Continuing on, we had the pandemic hit. You see housing. We had the American Rescue Plan Act of 2021. Why did I include this in housing? Because this was actually a big piece of legislation for a lot of aspects of life, for a lot of underrepresented communities, because it, as the name kind of perceives, is here to rescue and help people during a time of turmoil. Oftentimes, especially in housing, this actually provided people with some form of rental assistance. So when individuals were not actually able to pay for their mortgage and or their rent during the time of the COVID-19 pandemic, they will actually be able to apply for specific funding and actually mention that. This also goes into the area of utilities. So if you had specific bills that you had to pay for that you couldn't afford, you were able to, again, apply for assistance here to kind of help out with those insufficiencies at the moment. Continuing on, you've seen that Dr. Holler mentioned the Economic Opportunity Act. I also want to talk about now in 1972, so right after the Civil Rights era, you had the Equal Employment Opportunity Act. So now we're getting into the flow of everything of you cannot discriminate for people in terms of where they're able to work. And this is still something used to this day. Of course, there's been plenty of amendments going on to further expand the Equal Opportunity Act of 1972, but it is a big reason why there's, at least in verbal and kind of written communication, why companies are not allowed to discriminate who is actually able to apply and or be hired in a specific organization. And then transitioning to healthcare, this huge bill happened. Most of us actually probably know it's typically listed as the Affordable Care Act, the ACA, but the actual full name is the Patient Protection and Affordable Care Act of 2010, where President Obama passed this in March 23rd of 2010. And the major component of this, one of the titles, which is often highlighted, is the expansion of Medicaid. Kind of expanding on kind of play on the words, what Dr. Holler actually mentioned prior. When you look at the idea of Medicaid, right, and you look at who's accepting it, who pushes various areas, it's similar to that idea of the states are actually having the right to say who cannot and who will accept Medicaid expansion. So this expansion here essentially went by the poverty line. So poverty line at 100% was originally around Medicaid overall before 2010. But now after the Medicaid expansion of the Affordable Care Act, you push this to 138% of the poverty line itself, right? So now individuals who are just outside of that bracket, that income bracket of being able to qualify for Medicaid and government assistance for their healthcare now can and now have the opportunity to. I always tell at least students, imagine that you were making around poverty line and it was like 20,000, 24,000, and you were making 25, 26. Life isn't any easier. Right, life is still tough at $25,000, $26,000 a year. But now when you have the Medicaid expansion now, this is going to cover you a little bit further. It's going to give a cushion to around $28,000, $30,000 in terms of household income, where you may now be covered by governmental assistance overall. And then going into voting, this specific act, it was actually an amendment in the state of Florida specifically, where we actually had what is called the Voting Restoration Amendment, otherwise known as Amendment 4 for Florida, that was voting on in 2018, but enacted in 2019. And this specific amendment, it was actually a counter to allowing felons actually to have their opportunity to vote. So historically, the prison systems and jails and corrections overall are overwhelmed and kind of in a disproportion where they have typically, or you have any kind of rights and criminal rights of arrests of Black Americans and African Americans overall. So with that, if felons who were considered, or individuals who were considered having a felony weren't able to vote in the state of Florida, this kind of took away from a lot of voices of Black Americans overall. So this amendment was huge in the state of Florida to kind of restore that power back to individuals who have served their time, of course, outside of certain kind of crimes that were done, but giving that to the majority of individuals who are now coming back to the society after serving their time. The ability to vote has been huge as well for Black Americans overall. Next slide. So we've seen some of the information here on policies and outcomes, but now what is kind of like what's next? Where's the momentum? Where are we heading? A huge kind of announcement happened about, I believe, around 2 years ago, when we had former CDC director, Dr. Rochelle Walensky, announced and had a public recognition as racism as a public health issue. So this was an amazing kind of turn for health equity overall, because with the CDC being kind of the go-to, the biggest public figure, especially at this time, because we were in the midst of the COVID-19 pandemic, for their director to solely say that public health issue is racism was huge, and it had a lot of momentum. So you had a lot of other organizations such as the American Public Health Association, the American Medical Association, Harvard University, Cornell Universities, other politicians follow suit in the nature of Dr. Walensky, and actually acknowledging that racism itself as a whole, especially structural racism, is a public health issue. Next slide, please. And then as we continue, of course, not everything is going to be bright-eyed for everything. There is going to be some counters to things, of course, right? So unfortunately, there is this kind of notion of a lot of passing of anti-diversity, equity, and inclusion legislation. So it's a lot of kind of counteractive work done for diversity overall. What does that look like? So according to the Chronicle, they actually have what is called their anti-DEI, or essentially DEI legislation tracker overall that you can follow. So throughout the United States, 82 bills have been introduced throughout 28 of their states. 12 have been kind of accepted and or approved and made law. All of them, though, are essentially anti-DEI. So essentially banning this either on the educational standpoint for schools and or organizational and company standpoints in terms of employment. Next slide, please. But On the flip side of that, you do have a lot of organizations who have dove even deeper with health equity and equity as a whole, right? So they ended up prioritizing. Many of these organizations actually have it in their mission statements and or some form of policy statement where they're actually planning long-term to make sure they prioritize diversity, equity and inclusion, and health equity. A lot of these are large health organizations that often some of us actually look up to and or participate in overall. Again, some of them are similar to the ones listed in the last slide. The American Public Health Association, American Medical Association, American Hospital Association, and the Association of Schools and Programs in Public Health. Highlighting two of these, specifically the last two, the American Hospital Association in 2020 added a section to their annual survey for hospitals where they actually have to talk about and address the social determinants of health and the various programs that the hospitals are actually putting in place for social determinants of health in the communities that they serve. And then the Association of Schools and Programs in Public Health, which is often an accrediting body and often a large governing board of a lot of various schools that we all may be interested in, are actually making sure they prioritize diversity in their workforce that they're actually trying to help. Because of course, previous research has actually shown that more diverse workforce are typically going to actually go back and serve in communities that they recognize themselves with and them themselves also identify with as well. Next slide, please. And then there's also huge increases and improvements with research on health equity. So we had essentially a massive surge on anything equity-wise during the COVID-19 pandemic, because of course there was a lot of also social injustice kind of being highlighted during this time as well. So that didn't stop just in the area of equity. Health equity rose tremendously, and this is the most we've ever seen in terms of research articles being published in the area. On top of this, there was also an increase in terms of grant funding of projects targeting towards health equity in general, but even more so kind of the idea of people and individuals who identify from being a historically underrepresented group or background are now highly encouraged, where they actually are able to now have some form of help in terms of obtaining grants for these specific areas. And then lastly, you also have the establishment of centers and institutes primarily focusing on health equity, such as the Meharry Institute of Global Health Equity, the AMA Center for Health Equity, and the Johns Hopkins Center for Health Equity, where they all are doing various either health equity research and or health equity programs in their communities. And essentially, let's try to go towards the area of wrapping things up is what can everyone else do now as we continue to march forward? What can I do? What can you all do to play your part into keeping sure that health equity is kind of progressing and not going towards the area of the anti legislation overall? So the first and foremost thing is importantly to be open-minded and have some form of evidence-based research and knowledge. A lot of the anti-DEI legislation actually capitalizes on some gaps and sometimes when people present certain programs. So we want to make sure that we're able to present all evidence we can when we actually are promoting anything that deals with diversity and health equity. Always serve as terms of an advocate for health equity. Anytime you're doing in terms of public health work, or if you're interested in going into medical school and actually conduct medical practices, it is ultimately extremely important to have advocates for health equity. Nonprofits and organizations such as NGOs are oftentimes always doing work in communities, whether it's health equity or equity in general. So you can always volunteer, participate, look out for these individual organizations that are typically doing great work for underrepresented communities. Educate those who may be unaware of various disparities, and maybe they're just on the idea of they just don't know of some of the structural backgrounds and history of various disparities in terms of health and in general. And then last, but definitely not the least, probably one of the most important ones is to vote whenever you can. And this means on all levels, whether it's local and or state, because oftentimes a lot of these policies are at the local and state level. And in order for someone to essentially go up into federal power, oftentimes as well, they are at the state and the local level as well. So that is important to remember. Vote at all aspects, local, state, and federal, and make sure that you advocate for various aspects of equity and health equity for individuals from all forms of communities. I think that might be it. So that's kind of our timeline of everything of overall of leading us from where we've been to where we now are and where we hope to be. So again, we hope that you all are going to be able to be great advocates and peer advocates towards better health equity. I'm going to pass it back to Dr. Navarro, who's going to lead us to our moderated discussion.
Thank you so much, colleagues. Great presentation. I'm going to jump to our Q&A because we have a little bit of time and we have a couple of questions from our audience. So Riley asked, have you guys looked at how the medicalization of childbirth, such as Marion Sims' shift from midwives to OB care, affects the racial health disparities among Black mothers and infants? I would like to know your thoughts, if so.
Anyone want to stop on that one?
Well, Dr. Forbes, you and I were at a presentation just the other day from one of our undergraduate students who was actually looking at a similar topic. And Riley, I'm going to offer you a less than satisfactory answer. I personally have not looked into any sort of differences in infant and maternal mortality or health associated with midwifery or doula work in comparison to OB work, but there clearly are cultural contexts at play within what's considered normal and a preferred method of childbirth for a particular culture versus that of another. During a discussion Dr. Forbes and I were having with our colleague Dr. Van Heel after a presentation from one of our students, for example, in the Caribbean, it's not uncommon for Caribbean women to have a midwife of some sort to help them through the process. Here in the States, I love your term, the medicalization of childbirth. We can think about the medicalization of health, looking at disease and poor health being the consequences of it and of a lack of access to care, which clearly it is not. But when it comes to childbirth, that's a fascinating idea. All that to say, Riley, an unsatisfactory answer. I personally don't know the data on that.
Thank you, Dr. Haller. We have a question from Satish. Civil rights gains can face backlash from political and policy shifts. This may impact public health initiatives and funding for programs aimed at reducing health disparities. How can public health progress be protected from political and policy shifts associated with civil rights efforts?
I mean, I probably got to tag team with everybody on this one. So just to answer this one overall, the hard part with this is kind of a similar backlash that the Affordable Care Act got. This initial kind of wave to provide more coverage to all individuals was hit backlash because there is nowhere on our Constitution where healthcare is a requirement or is considered some form of right. So I think to answer your question, Satish, you're always going to have some form of political battle when it comes to anything dealing with public health. And I think another thing to add on top of that, we are typically investing heavily in medical health. So if we do have any kind of rights towards anything towards health, or if any politician or policy change is going to happen initially in the initial wave, it's probably going to be geared towards medical health first. With that being said, a key part of that is that advocacy for more public health programs and initiatives, kind of working with a lot of organizations and nonprofits that are doing a lot of this kind of education work already as well. And a part of that is also maybe even looking into our medical colleges and our medical schools and making sure that medical professionals are connecting public health to the work that they do. They're making sure that their patients that they see are understanding the importance of public health and not just the medical care that they receive as well. And the goal for that would be to have a long-term effect. It might not be something short, just due to some of the battles that would have to go through that. But hopefully long-term kind of shift and change. And then Dr. Pinnock, I don't know if you want to get a chance to add on.
Hi, Stacy.
We have one last question from Mahima. Thank you for joining us. Knowing that political and social determinants of health impact mental health, what can be done to advocate for increased mental health access in private sector and public sector workspaces? I'll answer that one. I think what my colleagues highlighted was voting. There's a lot of legislation around behavioral health, mental health, and supporting those bills, supporting that legislation. I think that's a very important aspect of it as well. We have medical health and we have public health, and then we have behavioral health that's kind of off on the side. I think one of the important things is bringing it closer together so that we are looking at overall health and not just the rest of the body without the head. So I think that's a very important aspect there, and voting and supporting those who are putting these legislations together as well. Dr. Holler, I don't know if you want to add anything to that. I know we've had some discussions about that.
No, for the sake of time, I won't jump in on the mental health access. If time is left over, I'd love to jump back to Satesh's thing, but I'll sit on my hands for right now.
So let me ask our host, do we have time for another question, or are we at the end?
Sorry, yes, we can keep going. That's fine.
Okay, wonderful. So we had a question in the chat. How can we as young policy students begin to address these disparities? I think everyone has touched on that a little bit. But interesting question to that is, if healthcare is an industry, how can we change it to a system?
I'll go ahead and jump in. I think those two questions I'm going to smush together and kind of call back to Satish as well. One thing I failed to bring up during my section is this notion of voting and representation and health. The way our system works, or the way our political system works, is we elect folks to go to Congress, whether at the state level or the federal level, to argue on our behalf. You'll hear people say, oh, we don't have a democracy in America, we have a republic. Whatever. There's a democracy, but technically speaking, it's a republic because we are electing folks to go speak on our behalf. So to the extent to which we do not have individuals voting, your voice is not going to be heard in the deliberative body, in the halls of Congress, where decisions are getting made about transforming from an industry to a system, about alleviating health disparities through social programming and protection of rights. If you're not voting, your voice is not heard. Your representative has no obligation to care at all about what you have to say, because you're not supporting him or her. They're not accountable to you. But if you're voting, they're accountable to you. And interestingly enough, because of this, we've seen noteworthy changes in health status as we've gotten minority populations in particular greater and greater access to voting. Whenever women, for example, were finally given the right to vote, guess what happened to maternal health, child health? It improved, because suddenly policymakers are being held accountable by voters, female voters, to have to say something on their behalf inside Congress. Policies have to get passed. I want to jump on my old man soapbox for a second. You know, if you want to do something, you need to know what's going on in the world. Quit scrolling through whatever social media of your choice and focus on what's being determined at the Supreme Court of your state. What's being determined at the Supreme Court of the United States? What's going on in terms of your local town council? Pay attention to those things so you have a moment to have your voice heard. And as such, we can transition from a industry to a system. We can try to alleviate disparities in health.
Thank you. I forgot that was my cue. We have another question. How do discriminatory practices within healthcare systems perpetuate health disparities?
Yeah, I'll hop on that one first. I mean, we kind of touched on it throughout everything. Well, if you think about similar to education systems, right? Where I kind of talked on the idea of how they're funded. Health systems are not necessarily funded the same way, but remember, kind of backtracking to the last question, they are a business, they are systems. They are an industry overall, because remember, in the United States, they aren't necessarily a right per se. So when you look at everything, look at where your large health systems, your worldwide known health systems that are given the grade of the best hospital in the country, in the world, look at where they're located, right? Those are challenges I would pose to everybody here. I mean, because they're put in areas that they can know they are going to be financially sound for the most part. So of course, that's going to have some form of discriminatory effects if, let's say, someone from a certain community or a Black community overall has some form of health effect or health issue going on, but there's no one in their neighborhood. There is no perfect, there is no physician that specializes in a specific area because they're on the opposite side of a city, right? Or they're on the opposite side of a county or sometimes state. So they have no real quote unquote access, right? They may be able to get to a hospital within 5 minutes, but there is no one there that specializes in the care that they need, right? So that's just one way. On top of it, oftentimes you just have various biases, such as implicit biases that are already there, already present. You all are here because you are learning it. And oftentimes I think when we're in the healthcare industry, we often forget that there are these implicit biases and there's these various notions that people already have that may alter how, not necessarily public health, but medical, how treatment is given, how priorities are given, kind of going back to the maternal health kind of situation. Oftentimes with Black mothers, one of the biggest things that we've seen is the lack of pain medication and pain management for Black mothers and Black women overall, because they're essentially assumed, and there's a huge implicit bias that they're able to tough it out, right? They're able to get through whatever pain that they're going through at the moment. So just in terms of some of the practices, those are also kind of there just on the idea of why we need some of these DEI efforts within healthcare systems, because we need for individuals to understand that there is such thing as an implicit bias. One thing to kind of counter implicit bias is to accept and acknowledge that it's there, right? But to kind of go in the opposite direction and get rid of anything that's dealing with DEI and getting rid of the idea of understanding an implicit bias, all you're doing is making the opportunity for there to be some form of ignorance in that area and aspects, thus causing for kind of perpetual health disparities overall.
Thank you so much, Dr. Forbes. So we are at the end of our webinar. Thank you all for coming and attending. Allison, I don't know if you want to close it.
Sure. I just want to say a huge thank you to all of you. That was an absolutely fantastic webinar. This will be recorded. So if you want to, we'll post the link on our website. So everybody that's attending or participating, feel free to share the link. It'll be up probably by the end of the week. And we would love for you all to join us on our next webinar. It'll be on May 10th, and it's on public health in the 1970s, Legionnaire's disease. So thank you so much, everybody. Have a great day.
Thank you all.
Have a good one, you all.